Hi, so this video is going to be about anticoagulation and what are the indications for using low molecular weight heparin when we start enoxaparin, when we stop enoxaparin, and also a little bit about INR and warfarin in a few cases. So let's start. Every single time you see a patient, you have to check, are they on enoxaparin prophylactically? There's something called VTE prophylaxis, and then there's also something called treatment dose enoxaparin. VTE prophylaxis is something that all hospital patients who come to hospital get assessed for, and you assess their need for VTE prophylaxis. So you're trying to see, are they going to be immobilized? Is it someone who's quite fit and active outside of the hospital, but now they've come into the hospital and they're going to be immobilized for a longer period of time? So they need to be on something called a VTE prophylaxis. When it comes to these cases, we're going to be looking at think about it as a staircase. So, staircase going up the stairs is the risk of the patient to form a clot, and going down the staircase is what you give as an anticoagulant. So, think about a patient with a staircase. Think about this idea of something getting more and more prone to clots going up. And whenever we give anticoagulants, you are now making that patient more prone to bleeding, which is the opposite. Okay, so we said every time you review a patient, check, are they on enoxaparin prophylactically? Okay. Now we have a case. It's a 65-year-old with multiple myeloma who has back pain, and MRI has confirmed that they do have MSCC, metastatic spinal cord compression. You are going to start hypercalcemia treatment for this patient, and you're going to give them something called treatment dose dolteparin. Treatment dose dolteparin. So, what is the difference between giving dalteparin on admission versus an enoxaparin post biopsy? So, these are two different questions. These are two different questions. Giving them dalteparin after they have had multiple myeloma, MSCC, cord compression, dalteparin will reduce their risk of bleeding. Now, it can be given in two situations. It's an anticoagulant. So, the patient had cancer, they have an increased risk of VTE, and they've also had MSCC related immobilization. That immobilization increases their risk of being prone to a clot and getting a clot. That's the first point. So, a patient who's had a cancer and they've also had MSCC, now they're immobilized, they are going to be more prone to a clot. We have something called Virchow's triad, and that is something which you can remember with the She mnemonic. So, stasis, anybody who's prolonged immobilized, S for stasis, H for hypercoagulability, E for endothelial damage. Any of these things can be triggered by someone. Stasis can be triggered by someone who's immobilized for a long period of time. Endothelial damage can be triggered by a liver biopsy. So you have a patient who had a liver biopsy. You can give prophylactic enoxaparin after the biopsy. Dalteparin on admission was given to prevent any clots from forming. After they have a liver biopsy, you are then going to give enoxaparin post liver biopsy. What's the point of giving enoxaparin post liver biopsy? It will reduce the risk of bleeding. When you have a liver biopsy or you have an endoscopy, we have a patient who was having a scope and they were about to get an endoscopy. You're manipulating tissue. You're putting a needle in or you're putting a scope in. You're messing around with the tissue in the body. That is going to increase the risk of the patient bleeding. So most patients will require enoxaparin post biopsy in that situation. Okay. A little bit about the management of MSCC, then we'll go back to another anticoagulation case. So, when it comes to metastatic spinal cord compression, this occurs due to a metastasis, a metastasis from a primary tumor. That primary tumor has spread and caused now another part of the cancer to migrate over to the spinal cord. Now it's impinging on the nerves. When it impinges on the nerves, and this can be over time as well, there's a real spinal cord emergency. You have a real neurological emergency because suddenly, if that nerve impingement gets so bad, that nerve compression gets so bad that it leads to compression on that nerve, you can get permanent loss of nerve function, you can get permanent neurological dysfunction, and you can get nerve damage as well. So you can give them radiotherapy. Radiotherapy helps to reduce the size of the tumor that's compressing the spinal cord, and it helps to relieve the pressure on that spinal cord, on the nerves. What does dexamethasone do? Why do we give dexamethasone following this? Dexamethasone is a steroid. It will reduce the inflammation and edema around the spinal cord. It will reduce the inflammation and edema, so it lessens the pressure that we put onto those nerves. How do we manage hypercalcemia of malignancy? So we also said in our plan with this patient, she had hypercalcemia. How are we going to treat that hypercalcemia? You're going to give IV sodium chloride 0.9%. Give them fluids, because your first kind of strategy, rather than starting them immediately on bisphosphonates, there's like a spectrum of hypercalcemia treatment. So when it's someone who's got hypercalcemia that's mild, you can give them IV fluids, and then later on you can give them bisphosphonates. Okay. So what have we talked about until now? We've talked about the need for prophylactic anticoagulants. When a patient comes into hospital, we've talked about giving them VTE prophylaxis. We've talked about the patient being immobilized for a longer period of time, leading to them being more prone to clots, and that's why we give them VTE prophylaxis with low molecular weight heparin like enoxaparin. Right. Okay, we've talked about patients with cancer being at more prone and more risk of getting clots. We've talked about why procedures like a liver biopsy and an endoscopy can also require enoxaparin. Why that would trigger Virchow's triad and then require something that is more bleeding, going down. If someone's got all of these risk factors that make them more prone to clotting, you will give them something that will make them more likely to bleed. Well, basically a blood thinner, but don't look at it as making them more likely to bleed. But that's how you weigh up kind of your decision making. But what's important is that you give them blood thinners. So this is a patient that shows, a difficult situation. You have a 79-year-old female with pneumonia who has metallic mitral heart valve. Her INR was 1.5. An INR of 2 to 3 is normal. So an INR of 2 to 3 is normal. This lady was prescribed low molecular weight heparin as a bridge in addition to her usual warfarin dose. She was then continued on low molecular weight heparin and warfarin, which is a no-no. You do not give warfarin plus a low molecular weight heparin for 3.5 weeks without any monitoring. This lady unfortunately died because she then had an upper GI bleed with an INR super, super high. What are the problems here and what's happening? Patients who have a metallic heart valve, anybody who has a metallic heart valve is more prone to getting clots. And patients who have a metallic heart valve who are more prone to getting clots should be on warfarin. So you give them warfarin. Warfarin is already a blood thinner. So if you're already giving them a blood thinner anticoagulation medication, you would then need something called a bridging dose. The way that a bridging dose works is you have something like warfarin, which is a long-acting drug. So it's something that's long-acting. And the thing is, I think she was going to have surgery. So you've got this patient who has this long-acting drug like warfarin. Let's say if it was another patient who was about to have surgery and they needed that blood thinner to be stopped right before surgery, because when they go into surgery, they're going to be, opening up, surgery's happening, they're going to be more prone to bleeding. So we do something called bridging, which is taking a long-acting medication like warfarin and then tapering that down, and then one of the days, once you know that its half-life has gone down, you then give enoxaparin, which has a shorter half-life. So you give another drug, bridge with another drug which has a shorter half-life, because that will then enable you to be more aware. You can check their PTA, PTT. You'll be more aware of their blood thinning properties in their body. You'll be more aware of which blood thinners in their body, which anticoagulant are they on, and how much anticoagulated are they. Are they super anticoagulated? So that's the benefit of using a short duration action drug after the long duration acting drug. The problem with this patient is that someone picked up that their INR was 1.5, which is less than 2 to 3. If it's a lower INR, they're more prone to clotting. So someone decided to bridge them with a low molecular weight heparin. And what was the problem? They were left on two forms of strong anticoagulants, warfarin and enoxaparin, and then they had a GI bleed. So you need to be monitoring. What's the take home point here? The take home point here is you need to be monitoring these patients regularly for their INR. You're checking their INR every single day. You're reviewing the drug charts every single day. And you're always checking what are the previous anticoagulations that they're on. Atrial fibrillation, and let's say a patient has atrial fibrillation, you give them warfarin, then got to enoxaparin, it's a really, really bad situation. Why might a patient who has an endoscopy be unable to get a scope if they were previously atrial fibrillated and they were already on warfarin and then they were on enoxaparin? Oh, the question here is you've got a patient who has a saddle PE, and they're unable to then get an endoscopy because they're previously already on enoxaparin. What's the high urgent issue? What's the high acuity clinical issue at the time? If it's a saddle PE is quite a large pulmonary embolism. And if you've got a large pulmonary embolism, then you are putting the patient on enoxaparin because they're at high risk of deterioration. This patient on enoxaparin is put on enoxaparin to reduce the clot progression. You delay the scope and you bridge the anticoagulation. Bridging means temporarily holding off of enoxaparin while closely monitoring for their clotting profile. Their clotting profile is the test that you want to be checking. That's how you think about it in your head. That clotting profile, that clotting progression that I talked about on the staircase, as well as the bleeding profile. Okay, this is a little PowerPoint slash notes thing that will just get you to think about anticoagulation and what's the way we think about it. When do we anticoagulate patients? When they are more prone to getting clots. If the patient is already at risk of bleeding, giving enoxaparin, which is a blood thinner, will make the patient worsen. What are we checking for each patient? We're checking their hemodynamic stability by checking their blood pressure, their pulse, and their urine output. What are the two types of heparin? You have low molecular weight heparin, which is known as enoxaparin, and you have unfractionated heparin. This is given as a subcutaneous injection. This is given as an IV infusion. And to check the profile of these drugs, we check anti-factor 10A because that's what's being inhibited in these patients. So you check the anti-factor 10A because that's what's also being inhibited. So what is the need for VTE prophylaxis? On admission, every patient is assessed for whether we prescribe VTE prophylaxis. And sometimes a lot of young people that come to the hospital, sometimes the fact that their mobility will be reduced because they're so active outside of the hospital, just having that notion of their mobility is going to be reduced once they're inside the hospital is enough for prescribing VTE prophylaxis. What do we check in each patient that we're prescribing VTE prophylaxis for? You check their kidney function because if any patient's kidney function drops, then they're going to have accumulation of that low molecular weight heparin in their body. And if they're going to have accumulation of that low molecular weight heparin in their body, then that is going to be too high of a blood thinner. That is going to be too high of a bleeding risk. Okay, we also check the patient's weight. So there's guidelines for less than 50 kilograms, this is the dose of enoxaparin we prescribe. More than 50 kilograms, this is the dose of enoxaparin we prescribe. Okay, so unfractionated heparin can be given as an IV infusion. Low molecular weight heparin has a longer half-life. Okay, so these are the topics that we can cover, which is VTE prophylaxis, stroke prevention and atrial fibrillation, types of heparins, and DOACs like apixaban and rivaroxaban. So edoxaban as well. Why is organ failure important to consider? So, liver or kidney failure will lead to accumulation of the drug, so always be careful in patients with kidney failure or liver failure. What are the tips for on the wards? You have to review your drug charts every single day and check, is the indication for why they were prescribed enoxaparin in the first place still active? After surgery, we do not give anticoagulation within a certain time frame, check your trust guidelines, but within 48 hours, is hemostasis achieved? And if hemostasis has been achieved, hemostasis is also another word for that clot formation ladder. So if hemostasis has been achieved, then, and if the patient is prone, if they've got some sort of bleeding risk prior to surgery, then you weigh up the pros and cons of prescribing that anticoagulant and continuing that.